Thank you to the Society for Cardiothoracic Surgery, Great Britain and Ireland for the opportunity to contribute again to your annual meeting. I've been asked to present to you a perspective on COVID-19 from a thoracic surgeon in North America. What will likely persist, must change, or finally dissipate, as we all hope this virus will too. It's an honor to be back with you, although the back is a virtual term, given this global crisis. I'm nevertheless grateful for this opportunity to be with you, my friends and colleagues from the UK and Ireland, if only virtually and for a short time. I have no financial conflicts of interest to disclose. My only disclosure really is to say that while many of you know that I am Canadian, over the past 20 plus years of living here in the US, I have enough United States baked in that I will certainly be giving a mostly American perspective. I will also note that much of the facts and figures that I will present today come directly or indirectly from the United States' most respected and experienced scientist in the area, Dr. Anthony Fauci. Although he had many obvious national obligations, Dr. Fauci also found the time and energy to be a guest lecturer in my daughter's biology course at MIT. And so I have had the privilege of listening in online to some of his teachings to them. One of the earliest medical adaptations with COVID was the development of a new visual pain scale based on Fauci himself, and with good reason. When I was first invited to give this talk by my good friend and colleague, Maninder Kalkat, the global map, and indeed the US map of virus prevalence, was much different. Here we have the map in the early days of the US in March of 2020, the Ides of March to be exact, with all the Shakespearean implications this assembly today is best suited to understand. Although we were told by our then president that the virus would perhaps rise to 15 cases and then miraculously disappear, in 1 month, this was our test positivity across the country. We began then on a state-by-state decentralized way. Since there was no recognizable national plan, we began work on isolating, working from home when possible, social distancing, and mask wearing. But the message from our national leadership, if I am to be polite, was inconsistent. 2 weeks after our July 4th national holiday, we had returned to significant outbreaks and test positivity. As you can see from this graph, in the US, we did not sustain the flattening of the curve. The inconsistency of message, lack of federal plan, as well as other factors, such as mass public protests and gatherings, led to an earlier and more pronounced spike than you experienced in Europe at that time. And then again, in the late fall and early winter, we faced yet again a surge of prevalence and hospitalizations. By late November 2020, only Hawaii, by definition isolated as a group of islands in the Pacific, only they did not show uncontrollable spread. But what have we done at Mayo Clinic during this pandemic? Well, to put it modestly, it's been a learning experience. This was one of our thoracic surgery division meetings. I'm certain that this Zoom format looks familiar to all of us doing meetings these days, even like this conference, by distance. When the definitive alarm bells went off in March 2020, Mayo Clinic did take a significant step back. We took counsel in the respected authorities, the World Health Organization, the National Institutes of Health with Dr. Fauci's leadership, and in surgery at Mayo Clinic, we sought understanding from our other colleagues, including many of you here. We curtailed surgical procedures initially, back to basically only emergent cases, with allowance for only selected oncologic cases, meaning that for the first 3 weeks, we were only able to do about 10 thoracic cases per week. This reduction was implemented to preserve capacity in our ICUs or ITUs. We instituted mandatory COVID testing for all elective cases and limited staffing in the operating rooms to minimize exposures. All trainees except for surgical residents were not permitted in the OR. And in an effort to limit aerosolization of virus, we put filters on our pleural drainage tubes. By April, having not experienced the same surge as on the East and West Coasts, as well as having experienced no notable adverse COVID-related surgical events, we cautiously expanded our surgical volume. By mid-May, we were basically back to full schedules and trying to assist with some of the volume from other centers who were not able to proceed because of regulations or capacity. By year's end, in terms of surgical volume, we were very fortunate to be only 11% below our 2019 volumes. In terms of working at a distance, we were very fortunate too to have a relatively robust experience and burgeoning infrastructure in the area of telemedicine. And it's because of this. We're in the literal middle of nowhere. This is a depiction of the distances of my thoracic surgery patients, with a third coming from within 500 kilometers, a median distance of 800 kilometers, and one third coming from beyond 1,600 kilometers. With this distribution, you can see that bringing people back for what is usually an anticlimactic follow-up visit can be challenging and frankly inefficient. Here are those same distances plotted around the Midlands for perspective. Because I felt strongly about surgical follow-up, a number of years ago, I partnered with our Center for Innovation at Mayo Clinic to develop a web-based communications platform that was secure, user-friendly, and integrated with our electronic medical record and patient portal. Over time, it has evolved. And over the years, we set up standards and ironed out many of the early wrinkles, such that we developed experience and a comfort level for both us and our patients. This is a cohort of our first few years of patients, a standard mix for a thoracic surgical practice. In that first cohort, we saved over 500,000 kilometers in travel, or just over 13 circumferences of the Earth. From a safety statistics standpoint, you can see that for every 1,000 patients seen by video visit, actuarially, we avoid one serious traffic injury or fatality. From the environmental standpoint, just in our first cohort, we saved over 90 metric tons of carbon dioxide emissions. Now I don't feel as bad when my laparoscopic cases go longer than anticipated. Furthermore, the median length of surgical follow-up visit ends up being somewhere around 7 minutes. So well before the pandemic hit, we had published on the benefits and even an in-depth economic analysis of video follow-up. That was our lead-in with post-op follow-up by video. What about the initial consultation previously prohibited due to interstate licensure issues? While the exigencies of COVID, however, created a need for access that allowed loosening of the current regulations, allowing us to confer and even with first consultations, do a video visit with patients across state lines. This is my cohort of initial consultations since the regulations changed because of the pandemic. The demographics are remarkably similar. The distances have slightly dropped, but are still in the very similar ranges. The median distance is 443 kilometers, or the distance from London to Middlesbrough. A tip of the hat to my colleague, Joel Dunning. The duration of the consultation is understandably longer since it's a first initial visit, but still remarkably reasonable at around 20 minutes. And the distance we save for these first 89 patients is just under 3 circumferences of the Earth. Other aspects to understand and consider are those of those seen, 80% had an indication for surgery, and of those with an indication, 94% came to Mayo Clinic for their surgical procedure at a median interval of 20 days from their initial video consultation. This demonstrates that once you meet with the patient, even by video, you can develop a meaningful bond that is usually sufficient to have them travel for their surgical care. So in my closing moments, I don't have any more clairvoyance than any of you. My sense, though, is that we're making sufficient and significant improvements in curtailing the tragic and devastating effects of this virus through vaccine dissemination and continued public health measures. When will we emerge and how that will look remains to be seen. Hopefully, we will have learned from this global calamity, and some of that learning will be in the surgical domain. I do believe telemedicine will shrink distances and provide access to experts for otherwise isolated and underserved populations. What is impossible to overlook, though, are the significant racial, ethnic, and socioeconomic disparities uncovered when considering the severity and devastating effects and human costs of COVID-19. Which brings me to a book that I highly recommend, even if you're not a football aficionado. It has lessons on understanding the game, but more importantly, if one digs deeper on understanding the world, it breaks down sports into strong link sports dependent on a singular star for success, like basketball. The team and its success is defined by its central star. And weak link sports, like football, which depend on a higher level of team interaction, where the team is more defined by its weakest player and where the singular star cannot carry the team alone. What our current pandemic has shown us is that we live in a highly complicated, highly interconnected, and highly interdependent world. In other words, a weak link world. The pandemic uncovered our interdependencies and exposed our numerous vulnerabilities and how poorly we have paid attention to them. The pandemic has exposed how we spend all our attention on the 99th percentile and not enough on the 50th percentile and below. All of the exotic therapeutics machinery are not what we needed or remarkably still need. Of course, we benefited from the high-tech solutions to expediting a vaccine, but we clearly needed more nurses and simple supplies like masks and gowns, as well as access to care. We have to be careful in our aftermath of the COVID-19 pandemic that we don't fall into the trap of most historic events that fill our libraries, that the history is written by the victors. It will be unfortunately very easy for those of us who have survived COVID-19 to downplay the catastrophic loss of life, over 3.3 million deaths worldwide to date. This should not be downplayed as just some culling of the herd, that the weakest weren't able or even meant to survive, and that those who did survive did so because we were somehow stronger or better. What it should truly make us think about is how we've structured society such that the vulnerable are indeed so vulnerable. And we do this at our own peril, since one of the biggest lessons of this pandemic is that we are all interdependent. There is thankfully hope on the horizon beyond the current storm clouds. We have new leadership in the world that recognizes the true nature of our current situation and their responsibility to act and to lead, and the importance of giving science its place at the policy table. We also have the promise of vaccines. And then we must plan, restructure, and prepare for the next global crisis and how we will manage it together better. Thank you for this opportunity to be with you again. I look forward to the discussion.
Ladies and gentlemen, it is a real pleasure being here to present some results from the cardiac surgery UK multi-center study during COVID-19. This time to assess the ability to maintain general cardiac surgery services. During the COVID pandemic, an increased number of patients required critical care beds to receive advanced life support treatment. This led to a reduction of capacity both in facility and NHS workforce, and hence a reduction to deliver normal levels of cardiac surgery. We aim to assess the effects of the pandemic on healthcare resources to deliver cardiac surgery by looking at theatre activity and beds availability. As you know, we designed a multi-center UK study to assess the cardiac surgery service provision during the COVID pandemic. This is sub-study 5 to concentrate on healthcare resources as indirect measure of the ability to provide cardiac surgery services. Primary outcomes analyzed were in the number of theatre lists available and percentage of utilization, and the number of cardiac surgery beds, both in the post-operative ward and ITU setting. This was a retrospective analysis of prospectively collected data at each participating center. A total of 11 centers were recruited in this sub-study, and the geographical areas are depicted on the UK map. Study period started in May towards the end of August 2020. In terms of theatre availability, this graph depicts both theater availability in blue and utilization in orange, as well as the number of emergency theaters in gray. The area depicted in yellow color marks the lockdown period in the UK. And as you can see, there was a clear reduction both in theater availability and percentage of utilization, starting immediately after the lockdown, with a minimal number achieved around mid of April and increased activity after that. A third of the participating centers had to stop their activity completely during the early weeks of the pandemic, and only 2 centers were able to maintain the same theater utilization as pre-pandemic times. The ability to provide emergency cover varies significantly across different regions, with some areas even having to stop emergency cases during the early weeks of the pandemic. In terms of bed availability, the number of beds on the ward depicted in blue decreased significantly after the lockdown, but started recuperating afterwards, whilst the number of ITU beds in orange was maintained more or less throughout the whole pandemic period. As we were seeing, the beds on the ward were significantly reduced, and this is explained by the closure of the common surgical base to guarantee COVID-19 free areas. Quarter of the centers were able to maintain pre-pandemic capacity. Another quarter lost their post-operative beds completely, and the remaining 50% suffer a reduction to an average capacity of 62%. The ITU beds were overall protected by ring fencing beds and by redeploying staff to ITU environments. And it was 54% of the centers were able to maintain the same capacity as before the pandemic, but the other half suffered a reduction to an average of a third of their activity. To conclude, there was a significant regional variation, and some of the regions have to cancel their surgical activity completely immediately after the first lockdown in the UK. The dedicated cardiac units seems to be protected, while the units who were located in general hospital suffer more reductions or even have to stop their cardiac activity. This study highlights the potential benefit of regional network approach in healthcare resources utilization in order to maintain cardiac surgery services during a pandemic. Thank you very much to all the contributors to the study and for your attention. I will be happy to discuss this topic further during the question and answer session.
I enjoyed that presentation very much, Dr. Lopez Marco. What have you learned from the pandemic that you will continue to do differently once, God willing, the pandemic is in the rearview mirror and COVID has passed from the community?
Thank you very much, Dr. Puskas, for your comments. Yeah, a lot of lessons learned. And as you have seen, this was a multi-center study, so there was huge variability among different regions and different hospitals. But if I have to comment on our particular experience here in London, for the second wave, we took some home messages from the first wave, although there are things that we couldn't escape, like, for example, having a lot of the staff in ITU redeployed to attend the ITU crisis in the COVID areas. So despite of all our efforts, there are still, when the numbers increase, I think that the cardiothoracic centers have to sacrifice and work with very limited resources to maintain also our own activity.
In New York, in the first wave, we were faced with a very, very steep wave that completely engulfed our hospitals. My hospital in particular became 100% occupied with COVID patients, and we did not do elective cardiac surgery for almost 4 months. During that time, every resource in the hospital, including all of the cardiothoracic surgeons, intensive care doctors, nurses, nurse practitioners, physicians assistants, residents, and fellows, were all devoted 24/7 to COVID care. So there wasn't any confusion or uncertainty about what needed to be done. There was no coronary or cardiac surgery to be done. All those patients seemed to evaporate. And the hospital was inundated with the COVID patients, so that we literally had patients in the hallways, and we tripled our ICU capacity by building out makeshift ICUs on our regular wards. So it wasn't hard to know what to do. We found it more difficult to turn the lights back on when it was all over. The first wave passed, and last summer, and even now, as we ramp back up to more normal volumes of cardiac surgery, we discovered that some of the personnel who were redeployed chose to take early retirement. I think there's a lot of PTSD, literally in our teammates, and we have a staffing shortage now. We are trying to recruit personnel to do even some basic functions. For instance, clinical research in cardiothoracic surgery was halted for the better part of a year. And now we have to rehire and retrain infrastructure people to do clinical research in cardiothoracic surgery. I have found it much more difficult to restart doing what we used to do than it was to stop doing what we used to do and to repurpose ourselves to be COVID doctors. Our next presentation is the Pan London Emergency Cardiac Surgery Service, PLECS, a response to the COVID-19 pandemic. The speaker is Dr. Azhar Hussain.
Hello, my name is Azhar. I'm an ST6 trainee in London, and I'll be talking about the PLEX, the Pan London Emergency Cardiac Surgery Response to the COVID-19 pandemic. I'm sure you are all aware the coronavirus has caused a significant economic, political, and public health impact on a global scale. The natural history of the disease and the surge in need for invasive ventilation has required the provision of intensive care beds in London to be reallocated. NHS England have proposed the formation of a Pan-London service, and in this presentation we're going to outline the experience of setting up and delivering a pan-regional service for cardiac surgery. There are 7 NHS centres that provide cardiac surgical services in London, covering a population of 8.5 million. An initial Pan-London conference call was set up in March 2020, and at this point, almost all units have stopped any surgery. 2 centres, Barts Health Centre and Harefield Hospital, were chosen as command centres or delivery centres, and this was based on several factors, namely their capacity, their geographical location, and the absence of an on-site A&E. It was felt that having to accommodate acute admissions via A&E would make maintaining a COVID-free environment quite challenging. The command centre was staffed 24 hours. There was a dedicated schedule team, a senior surgical registrar, there was a dedicated PLEX consultant, and there were twice daily virtual meetings between the command centres and the non-delivery centres. And this was to ensure efficient patient handover as well as ITU bed capacity as well. The PLEX consultants, although the majority work from Barts Heart Centre, they could be from any of the non-delivering centres, and honorary contracts were made available for them. The first duty in developing the PLEX pathway was to define the cohort of patients that would be eligible for referral and treatment. Elective patients were not treated within the PLEX pathway. Urgent from-home patients with life-threatening anatomy or with worsening symptoms were prioritised according to capacity. And level 3 and level 4 patients were the in-hospital patients, those patients with unstable symptoms which required hospitals within this admission, as well as those who were emergency patients such as aortic dissections. This was our pathway outlining the pathways. Essentially, as you can see from the pathway, the plan was essentially to try and keep a COVID-free environment at all times. Preoperative workup, such as angiograms, Dopplers, lung function tests, and CT tests, were all done at the non-delivery centres prior to transfer. The key issue in our hospitals was to maintain a COVID-free environment. All patients received what had another COVID-19 swab on arrival. And any patients who did end up turning positive after they had a negative in their non-delivering centre were then rediscussed to see if any other percutaneous options were feasible. There are operative and theatre considerations. PPE were donned as per Public Health England guidelines. We reduced staffing during intubation. There was a 20-minute window before staff were allowed into theatres. There was dedicated staff to remain outside of theatres, and a full protocol of this will be shown later. As I'm sure all hospitals have now created coloured zones with dedicated side rooms for any urgent elective patients and keeping them out of contact with other patients. Telemedicine has really excelled in the last year. Almost all our follow-up patients and clinic appointments were performed virtually. Any new patients or patients who did require face-to-face visit were contacted prior and screened before their visit. And a lot of our staff have been given remote access, both clinical and managerial staff, to avoid any unnecessary visits to the hospital if at all possible. We did publish our outcomes, our operative outcomes during the period where we were maintaining a COVID-free environment. 156 patients underwent major cardiac and thoracic surgery over this study period. Overall mortality was 9% in the cardiac patients and 1.4% in the thoracic patients, and this was in line with the calculated Euroscore and logistic Euroscores. There were no patients who died post-operatively as a result of COVID-19 infection. We've also published our pathway, which details everything that I've been talking about over the last few minutes. There's also a lot of information on the SCTS website, again, where our PLEX protocol, as well as an aortovascular protocol, as well as a dedicated 40-page theatre protocol outlining all of our algorithms, which are all available. Thank you very much.
Dr. Hussain, that was a great presentation. And of course, we're reliving a pretty dramatic time in the life of our society and our profession. You commented that there were no patients in that group of 150 odd cardiac surgical patients who died of COVID after surgery.
Yeah.
And zero. Because that certainly is different than our experience here in New York. We had several patients who had successful emergency cardiac surgery. I can think of one aortic dissection, one terrible endocarditis, and one acute coronary syndrome patient, all of whom survived the surgery, went home, and 2 or 3 weeks after going home, contracted COVID in the community, were admitted to local hospitals and died. Obviously, cardiovascular patients are a more vulnerable group than most to die of COVID, but we certainly saw that happen. Fixing their cardiac disease did not seem to make them impervious to the virus. And all of this, of course, was well before we had the vaccines.
No, absolutely. Thank you for your comments, Dr. Puskas. So I think what we were referring to in that paper was that there were no mortalities that we could see in the study in the immediate post-operative period after we introduced the protocols. However, we did see that the perioperative mortality of patients in hospital who did contract COVID-19 post-cardiac surgery was quite significant. And we did publish a paper where there was a series of 9 or 10 patients in a row in early March who immediately after cardiac surgery contracted COVID-19, probably iatrogenically or in the community, had their operation and then died, had a mortality within 10, 15 days of their admission. So I think that study was just referring to the in-hospital mortality as a result of the pathway, maintaining a COVID-free environment and ensuring that none of these patients contracted COVID-19 during their admission and did not then suffer the consequences of it. Now, in response to your other question, with regards to patients then developing COVID-19 in the community, we haven't actually, gone far ahead with the study enough to retrospectively look at that yet, and that may prove right, as you said, that patients do then contract COVID-19 in the community and then suffer from it as a result. So we haven't done that yet.
We note that many of the risk factors for coronary disease, for instance, obesity, diabetes, hypertension, are the same risk factors for mortality with COVID. And we think of our cardiac surgical patients as sort of hyper vulnerable. So from the beginning, we really quarantined the cardiac surgical ICU, ORs, and step-down unit. And to the very best of our ability, we eliminated in-hospital transmission of the virus, even well before we had the vaccines. PPE does work. If you are really religious about using it, it produces a near zero transmission. But those patients then go home to an environment that is not PPE protected. And in New York, when the virus was just raging through the communities, we were stunned to see successfully treated surgical patients go home, get COVID, and die. It was tough to watch. Dr. Lopez-Marco, do you have any insights on that event in your community?
I think, but for interest of time, we should move to the next presentation. Sorry about that, Azar. There are no further questions from the audience, and I would like to invite our next speaker, Michelle Lee, also from St. Bartholomew's Hospital in London, who is going to talk about COVID-19 positive patients.
Hello, my name is Michelle Lee from St. Bartholomew's Hospital in London. The title of the presentation I would like to share today is Cardiac Surgery in COVID-19 Positive Patients. Is delaying surgery the lesser evil? Objectives. We would like to review the outcomes of patients testing positive for COVID-19 in the early post-operative period following cardiac surgery, and also to determine the safety of delaying surgery in COVID-19 positive patients identified during pre-operative assessment. The coronavirus pandemic resulted in a novel multi-system inflammatory disease, particularly causing respiratory or renal failure. As the incidence of COVID-19 rapidly increased in the general population, we began to notice patients were having incidental positive tests in the early post-operative period. We therefore initiated pre-operative screening for COVID-19 and also delayed surgery. It is difficult to predict the appropriate waiting period between COVID-19 diagnosis in an asymptomatic patient who requires urgent surgical intervention. Depending on the cardiac diagnosis, there might be an option to treat patients medically with less invasive procedures, such as endovascular procedures or TAVI, or to defer surgery until there is a negative conversion of COVID-19 status. We aim to analyze the outcomes of cardiac surgery in patients who underwent cardiac surgery after recovering from COVID-19. So we've collected our data prospectively for all patients who underwent cardiac surgery in our center from March to July 2020. Our standard protocol for COVID-19 screening include 2 consecutive nasopharyngeal swabs for PCR RNA analysis, non-contrast CT chest to assess changes in the lung parenchyma suggestive of COVID-19 disease, lymphocyte count, lactate dehydrogenase, LDH levels. All patients undergoing cardiac surgery who had positive COVID-19 PCR were included, and our data were divided into 2 different groups, which were development of COVID-19 pre- and post-cardiac surgery. So this slide shows the results of perioperative diagnosis of COVID-19, and 9 patients developed COVID in the post-operative period. 7 were early, between day 1 and 9, and it's likely to represent the preoperative infection, which was not identified as we were not screening. And 2 late infections at day 23 and 37, both in long-stay ICU patients, and this may represent transmission from asymptomatic staff or visitors. Mortality for patients developing COVID in perioperative period was 44%. This has led us introduce a screening prior to surgery. So in our preoperative screening, we identified 10 patients who were diagnosed with COVID-19 and subsequently underwent surgery. Time from diagnosis to surgery varied widely based on method of diagnosis, clinical conditions, and urgency for surgery. So out of 10 patients, 4 patients by positive nasopharyngeal swabs, 3 by CT changes in the lung parenchyma, and 3 patients by a combination. 80% were male, and mean age was 65.8, varying from 45 to 76-year-olds. And cardiac diagnosis included acute coronary syndromes in 50%, acute aortic syndrome, decompensated mitral regurgitation, symptomatic severe aortic stenosis, infective endocarditis, and 1 infected aortic graft. And we had no mortality in this group. So in conclusion, from our experience, deferring or postponing cardiac surgery in patients with confirmed COVID-19 is safe and enabled surgery to be performed with favorable outcomes. By contrast, the diagnosis of COVID-19 infection in the early postoperative period was associated with high postoperative mortality and prolonged length of hospital stay. Thank you very much.
Thank you very much, Michelle, for that fantastic presentation. I think this reflects on how we were just catching up with the information that we had by the time, and how at the very beginning, without the strong diagnosis protocols, we had those bad results. But then when we established this preoperative screening, we actually, even on the patients who were positive, we managed to wait, and that's why we have those results.
I assume that even in that time you mandated COVID swab testing for admission to hospital for all patients, no?
So back in the time, as we suggested in the study, we needed 2 consecutive negative swabs and then the CT test as well.
Although at the very, very beginning, we didn't go. I think the first week of the pandemic was when we did, and for sure, for the cases, for our exceptions, we were never waiting for the negative swab. We were just taking the swab and going for the and waiting for the results.
Well, I'm seeing a note from our organizers in light of time. We should move on to the next lecture. Dr. Lee, thank you for your very good presentation again. You're making quite an impact on this year's meeting. Congratulations. The next topic is impact of COVID-19 on the mental health status of NHS staff, a staff survey in a large London hospital. I think this is an important topic. PTSD is a real thing. And quite frankly, it's endemic here in New York. The speaker today is David Icke.
Good day, ladies and gentlemen. My name is David Icke, and I'm a junior cardiothoracic clinical fellow at St. Bartholomew's Hospital. I'm here to present the abstract titled "The Impact of COVID-19 on the Mental Health Status of NHS Staff: A Staff Survey in a Large London Hospital." It has been well established in previous studies on SARS that pandemics exert an enormous physical, emotional, and mental strain on healthcare workers. Now, during the time of the active phase of the pandemic in 2020, the impact of the pandemic on the well-being of healthcare workers was yet to be established. Now, the aim of the study was to assess the prevalence of mental health disorders experienced by NHS staff during this period. We distributed an anonymous survey with demographic data and 3 questionnaires between 25th May and 15th June 2020. The Generalized Anxiety Disorder, GAD-7, and Patient Health Questionnaire, PHQ-9, were used to assess anxiety and depression respectively. The Health and Safety Executive Management Standards Indicator tool was used to assess work-related stress. Now, this is a tool that measures stress across 7 domains: demands, control, management support, peer support, relationships, role, and change. These results are then compared to benchmark data provided by the manual. This benchmark data is created by taking an average of these standards across multiple industries in the UK. A total of 302 staff members completed the survey. The demographic characteristics can be found in the table below. It's worthy to note that 96 participants indicated that they had been tested for COVID-19 in the study at this time. Now, I would like to remind you that at this time, testing for COVID-19 was quite difficult to come across, and the mean length of time of work was 11.8 days. 77% of this subgroup gave COVID-related reasons for their absence from work, including being symptomatic, self-isolating, or testing positive. This showed the high burden of absence from work during this period. The results, as indicated by the data collected, showed the prevalence of symptoms suggestive of anxiety within the population of about 41%. Females showed a high frequency of symptoms suggestive of anxiety versus males. And this was repeated when comparing data of nurses to doctors as well. Both results were statistically significant. And the prevalence of symptoms suggestive of anxiety in consultants versus junior doctors was 18% to 34%. However, this was not statistically significant. The results for depression also mirror the results for anxiety, with the prevalence of symptoms suggestive of depression being 42% in the overall study population, and males showing a prevalence of 28% versus 50% for females, while doctors showed a prevalence of 30% versus 48% for nurses. Both results were again statistically significant. In general, you could see that females and nurses were more likely to report a higher prevalence of symptoms suggestive of both anxiety and depression. The figure shows the summary of results for management standards as surveyed by the HSC MSIT tool. As we can see, management standards for demand control, manager support, peer support, relationships, role, and change were all above or at the 20th percentile, but below 80th percentile. We showed a need for improvement. Therefore, we can summarize that work-related stress was observed to be prevalent in our surveyed population, with the following standards: relationships, role, control, and change showing a need for improvement. Females were also observed to score lower than males for work-related stress across all management standards, with control and change being the worst affected standards with scores below the 50th percentile. Both doctors and nurses reported scores that were below the 50th percentile for control and change. However, all scores were between the 20th and 80th percentile. With the benchmark data, which indicated average performance and the need for improvement in all domains. And nurses were observed to score lower than doctors in domains for demand, peer support, and relationships. In conclusion, an analysis of comments made by those who filled in the survey showed that healthcare workers were anxious at the potential risk to families and friends, but also struggled with having to isolate from their loved ones. A further analysis of the comments made by nurses showed frustration with poor communication from management about new protocols, policies, and rota changes. Our data therefore suggests the high prevalence of generalized anxiety, depression, and work-related stress in healthcare workers. The COVID-19 pandemic, in relation to previous pandemics, has shown that it will persist for an extended period of time. It is therefore imperative that suitable interventions are made to strengthen the psychological resilience and capacity of our healthcare systems. Thank you.
A fascinating study, Dr. Ike. It was conducted in May and June of 2020.
Yes.
After the first wave and before the second larger wave.
Yeah.
It would be very interesting, and I wonder if you have any plans to do this, to repeat the survey this year, 1 year later, to look at how that sense of anxiety and depression has evolved. I'd also like to note that while the burden of the pandemic was great upon physicians and surgeons, it was a greater burden upon nurses. The honest truth is that much of the burden was borne by our nursing colleagues at the bedside, not so much by us rounding and seeing the patients. You know, I personally inaugurated our proning team in our ICU, but I wasn't, a daily member of the proning team. We had dozens of patients die in isolation in our intensive care unit without contact to family, and nurses doing FaceTime on their own personal iPhones to bereaved family members as the patient expired on the ventilator. This is a scenario that played out dozens of times, and that was almost always a nurse, not a physician or surgeon, providing that kind of remote personal contact at the most psychologically painful moment of that patient's care. So while we see in your data that nurses are reporting greater anxiety and depression, I think it's important not to assume that that's because they're somehow more psychologically frail than physicians. I think the honest truth is that they took a bigger hit than we surgeons did.
And that's so that's very true, and that's why the work-related stress we used showed that, because the nurses were reporting.
We've got our next presenter, Julie Sanders, who's going to talk about increased mortality in patients undergoing cardiac surgery with a post-operative diagnosis of COVID-19. Julie.
Many thanks to the SCTS for the opportunity to present our work, which identified increased mortality in patients undergoing cardiac surgery with a post-operative diagnosis of COVID-19. Early surgical studies have concluded that those with COVID-19 have a high risk of death, and that the surgery itself may actually accelerate disease progression in those incubating COVID-19. However, there is a lack of cardiac surgery-specific evidence, both in the UK and across the world. So we conducted a retrospective observational study, including all adult patients undergoing cardiac surgery between the 1st of March and the 30th of April 2020 at 9 UK centres. Data was obtained from local national data sets, linked to each centre, anonymised, and then securely submitted to the lead centre for analysis. And this is one of several studies that we've conducted exploring the impact of COVID-19 in cardiac surgery, all of which are being presented at this meeting if you're interested. So this table details the cohort characteristics and a comparison of those with and without COVID-19. To highlight some key points, 755 patients were included in this study, which represents a reduction in surgery of 52% compared to the same time in 2019. The majority of operations conducted in this early months were urgent and emergency, with more than 40% being complex cases. In-hospital mortality was 5%. 7% of patients had COVID-19, and those with COVID-19 were more likely to be male, diabetic, stay in hospital for an additional 5 days, and have considerably higher mortality rate, 24.5% versus 3.5%. and these outcomes remain significantly different after propensity score analysis. Overall, 66% of COVID-19 diagnoses were made post-operatively, and this table details the statistically significant differences between those diagnosed pre- and post-operatively. Those with a post-operative diagnosis were older, had a higher BMI, stayed in hospital for an additional 5 days, and had a considerably higher mortality rate of 37.1%. We found no difference in ethnicity, gender, operation type, urgency, Euroscore, ICU length of stay, or post-operative complications. Overall, there are probably 4 limitations to this study. Firstly, that the study reflects the initial snapshot of outcomes when services were adapting to the impact of COVID-19 in the UK, and certainly things have moved on in the last 12 months. Secondly, not all UK centres participated in this study, although we do have a wide geographical representation covering England, Wales and Northern Ireland, and including 3 large centres in England. Variable swabbing protocols were also observed across centres, and initially COVID-19 diagnoses were reliant on single negative swab pre-surgery. And finally, as with all retrospective database analyses, our data is limited by the data collected within those existing data sets. So data pertaining to cause of death and also the timing of post-operative COVID-19 diagnosis would have been beneficial, but was unavailable at the time of our study. So to our knowledge, this is still the largest cohort exploring cardiac surgery outcomes during the pandemic, and it reflects a snapshot of cardiac surgery when services were adapting to the impact of COVID-19 in the UK. Overall, we found that patients with COVID-19 had adverse outcomes, but that the greatest burden was in those diagnosed post-operatively. We suspect this has now considerably reduced with the change in practice and the introduction of more robust pre-surgical protocols. With those diagnosed preoperatively, recovering in a similar rate to non-COVID patients, and this is because potentially additional actions were taken at the time to reduce their overall risk. Of course, it is entirely possible that this pre and post-diagnosis divide is actually not a real phenomenon and is really a reflection of the poor and variable COVID-19 diagnosis procedures in the early phase of the pandemic. However, our results do actually mirror those found in the COVID Surge 2020 study. So that said, based on our results, we would suggest that robust pre-surgery diagnosis protocols are needed, and of course these have now been introduced. Also, effective strategies to maintain a COVID-19 free environment and perhaps dedicated to cardiac surgery hubs are required. Certainly normal activity was maintained well during the second lockdown, whereas in the third this has been extraordinarily different. Nevertheless, we should be considered with robust planning if we are potentially going to be living with COVID-19 for a little while into the future yet. Thank you for your attention.
Thank you very much, Julie, for a fantastic presentation about the results on the first wave. I have a question. I mean, in your last slide, you obviously highlight the needs. Do you think...
Julie, for an excellent presentation. If you may allow me, can I ask you what practice change have you had in your institution, and whether you've noticed a significant or marked improvement in what you just presented? Can you hear us?
Julie, I think you're muted.
Apologies. I think, thank you very much for your question. I think that a lot has changed in the last 12 months. Certainly more robust protocols for swabbing prior to surgery, plus for patients to have isolation prior to them coming in. So I think the opportunity for post-operative diagnoses is much reduced because we pick up any diagnoses pre-operatively. I also think that we have more robust swabbing protocols per se, as well as the isolation, and we're much more aware of and have treatment options. So I think the likelihood of us ever operating on COVID patients now is significantly reduced. I think the one of the key challenges is that, particularly in the third wave, so our biggest wave actually, is that we didn't have quite the same regional hub elements that we had in the first wave. So St Bartholomew's was one of the regional hubs for London. And I think keeping therefore a COVID-free environment is potentially a little bit more complicated when you're mixing elective and urgent surgical cases in the same environments as, say, COVID patients. So I think there are still areas that we can improve on, maybe for planning moving forward.
Many thanks to the SCTS for providing the opportunity to highlight our ongoing study and present some preliminary findings exploring the impact of the pandemic on recovery from heart surgery. At the beginning of the pandemic, although little was known, it was anticipated that living with COVID-19 would be stressful for people. Certainly, a recent study highlighted 30% of the Italian population had PTSD during the initial phase of the pandemic. We believe that this could be heightened in those having cardiac surgery, as we know that between 4 and 12% of patients experience PTSD after a cardiac event in non-COVID times, and those with higher scores are 2 times more likely to be readmitted to hospital. However, the health impact of a traumatic event can occur within 1 month, but can commonly be delayed by several months. Thus, we sought to explore the effect of the pandemic on recovery from cardiac surgery over a 12-month period. We undertook a prospective single-site observational study. Eligible participants included all adult patients undergoing cardiac surgery between the 23rd of March and the 4th of July 2020, but excluding those who were too unwell to participate or who were unable to complete the questionnaires. We collected 3 questionnaires: health-related quality of life, impact of events, and depression. And they were collected at baseline, which was a preoperative assessment, 1 week after discharge and 6 weeks after surgery. Participants had the choice of completing these questionnaires on paper or via an electronic system. All clinical data was obtained through existing local electronic systems, and we have an actively engaged patient and public involvement group. During the study period, 325 patients underwent surgery, and we screened 298. Of those, 203 gave written informed consent to participate. 7 patients were subsequently excluded due to changes in medical circumstances on not completing the baseline data, and so the final analysis is on 196 patients. Baseline, 1 week and 6 week questionnaires were completed in 100%, 65% and 78.3% respectively. The table on the right highlights the main baseline characteristics. Overall, participants were predominantly male, with a mean age of 63.4 years and underwent urgent or emergency surgery. Median post-operative length of stay was 9 days, with an in-hospital mortality of 0.5%. No patients had COVID-19 at the time of the study. This table highlights the key questionnaire results at baseline 1 week after discharge and at 6 weeks post-discharge. Data at 6 months and 1 year is still being analysed and collected. We found that the impact of the pandemic, i.e. the IESR score, was slightly higher than average, which is an average score of 12, on patients at preoperatively, but this does start to decrease after surgery. The proportion of patients with PTSD was at 17%, 13% and 12% at each of the time points, and is slightly higher than in other cardiac patients in non-COVID times. In terms of quality of life, the high preoperative levels are returned to by 6 weeks after surgery, although there's still a high proportion of patients reporting problems in undertaking usual activities and with pain. Finally, we also observed similar depression rates to non-COVID times, which are between 15 and 33%, although perhaps we are at the higher end of that range. Overall, we found both Euroscore and baseline measurements of each of the questionnaires was significantly associated with the scores at 6 weeks. So the results thus far suggest that perhaps the added impact of living through the pandemic may not have had a significant impact on recovery. Obviously, we have further analysis to undertake, but I think it will be really interesting to see the 6 and 12-month follow-up results to see if there's been any lasting impact on the recovery due to the pandemic. We'll also be able to relate those patient outcomes from lockdown 2 and lockdown 3, although direct comparisons will not be possible due to the varying clinical and organisational processes at each of these times. Finally, at the request of our PPI group, we are undertaking a qualitative study to also enable patients to reflect on the impact of the pandemic on their recovery and their surgery experience over the 12 months, which we will hope to provide a complementary detailed insight into the effect of the pandemic on their recovery. And for that, I'd like to thank the Cardiac COVID PPI group for their ongoing commitment and enthusiasm for this study. And thank you for listening.
I congratulate you on an interesting longitudinal study, Dr. Sanders. That really is important. I'm curious to see that the PTSD rates were as low as they were. And I wonder if that's because of a sort of a sampling bias, if you will. In New York, so many people were so terrified of COVID that many simply stayed at home and they ceased to come to cardiac attention. Patients would suffer a myocardial infarction and either live through it on the couch at home or die and go straight to the morgue. They were not ever brought to the hospital in the early days. That the EMS, the ambulance services, did not bring patients in arrest to a hospital any longer. They went straight to the morgue. So those patients who did actually present with accelerating angina, for instance, and have a coronary operation may have already self-selected themselves as sort of the stiff upper lip group who were going to take care of their heart problem irrespective of the raging pandemic around them. And perhaps they are less vulnerable to PTSD. What are your thoughts?
Yeah, I thank you very much for your comment and your question, which I think is really important and one that we have considered a little bit, certainly from when we were talking to the patients themselves when they were in hospital. And some quite like the safety. Actually, they did feel a safety of being in the hospital setting and felt that actually if they didn't die from COVID, they would die from their heart condition anyway. So why not give it a bit of a go, was kind of the general kind of feeling. What we actually found was when we were recruiting in the second and third wave, very different kind of perspective. You would definitely get that 50% or so of people that would just have exactly the same as that feeling as in the first wave. But we had a lot more people that were particularly more anxious about coming in. And I think we will see that in some of our declining to come in for surgery or delaying coming in for their surgery. So I think the qualitative study, complementary study that we're doing, which we've talked through, as I say, with our patient and public involvement group, will really kind of pick at some of that nitty-gritty kind of detail that we can't get from the validated questionnaires. But I think you're right, we found from an anecdotal perspective that there was a definite split in perspective.
Dr. Lopez-Marco, your thoughts?
Is there any special resources that we are providing to these patients who are anxious or need extra help?
So if the patients score highly on the questionnaires, we do offer them some psychological support if they wish for it. So we ring them back up and we say, actually, you scored quite highly, how are you doing? And some actually do refer themselves to their GP. Others have taken up our offer of an assessment and for some additional support. And particularly, we wondered from the first wave in particular whether the social isolation of them going home and being in isolation would have a particular impact. So we'll be able to look at that and how that maybe has affected over the whole year's recovery. But yes, we are providing that as part of the study, which actually the patients wouldn't have got otherwise.
I think we're going to find that in areas that were hard hit, a lot of patients deferred care and either died for lack of care or presented very late in the course of their disease and had different outcomes than they might otherwise have had. We, for instance, have seen post-infarction VSDs and left ventricular aneurysms, even free wall rupture from ignored ST elevation myocardial infarction, something that we just never saw before. And it's difficult to get the denominator for that group of patients because many of them simply weren't counted. They were deaths at home. But I believe that the medical cost of fear of COVID is not trivial.
I would agree, and we have been participating in another study with colleagues in Liverpool, actually that's a qualitative study, and for those that were emergency patients, what their decision-making process for actually going to the hospital was and how and if at all they delayed their decision.
Perhaps you could introduce the next speaker, Dr. Lopez.
Yeah, it is my pleasure, thank you, Julie, to introduce my colleague Martin Yates, who is going to talk to us about operative outcomes of the Pan-London emergency cardiac surgery response to COVID pandemic.
I would like to thank the Society for inviting me to discuss the outcomes of the Pan-London emergency cardiac surgery response to COVID-19 pandemic on behalf of my colleagues from all of the cardiac surgery centres within London. In response to the COVID-19 pandemic, elective cardiac surgery in London was postponed. 2 cardiac surgery centres were designated to provide a Pan-London emergency cardiac surgery or PLEX system. This was introduced on Monday the 23rd of March 2020 and ran until the end of June. All referrals were coordinated via a central hub, and we received referrals from 42 different hospitals across the southeast of England. Surgery was performed at St Bartholomew's Hospital in the city and at Harefield Hospital in West London. This is the geographical presentation of the cardiac surgery centres within London pre-pandemic, of which there were 7. And in a relatively short period of time, 5 centres stopped providing cardiac surgery, and this was provided just at Barts and Harefield. From the beginning of the pandemic, this is the weekly referrals to the PLEX pathway. You can see there's a large spike at the beginning, which essentially was all 7 cardiac surgery centres inpatient waiting list, which was transferred to these 2 hubs to be treated. And afterwards, there was a relative stabilisation of the referrals. Of the surgery performed, the majority were coronary artery bypass grafts or valves. However, including this were complex multiple procedures, major aortic surgery, septomyectomy, and myxomas. We divided the demographics and outcomes into 3 categories of urgency: urgent from home, urgent inpatient, and emergency and salvage. The majority of patients, as you would expect, were urgent inpatients, and these were at the beginning of the system. You can see these were doing normal demographics with a mean age of 64. Twice as many patients were male as female. The majority have good LV function, but a significant number have moderate or poor function. We had relatively normal bypass times with a logistic Euro score of predicted mortality of 7 and an actual mortality of 4.84. As our pathways improved and we were able to offer patients surgery in a COVID protective environment, and with a significant number of patients remaining on the outpatient waiting list, we began to bring in the most urgent patients from home. In this group of 218 patients, there was a mortality of 1.83% with a logistic Euro score of 4. And of note, of the over 100 coronary artery bypass graft surgeries in this group, there were no mortalities. In conclusion, the COVID-19 pandemic had a rapid and profound effect on the ability of the NHS to provide cardiac surgery. The Pan-London Emergency Cardiac Surgery Service provided a rapid, collaborative and effective service transformation within the NHS. PLEX allowed time-critical surgery to continue with good operative outcomes during the peak of the pandemic, and lessons learned from this process can guide us planning for future surges. In particular, we've been able to show that collaboration across multiple centres within London for the benefit of all of the patients across the area. Thank you.
Thank you very much, Martin, for this fantastic presentation. So this highlights a phenomenal collaboration among 7 centres with a huge number of patients covering the whole area of London. Could you please elaborate a bit more in the challenges that we face in the two hubs to coordinate all this, and whether what this implies for the future, whether there is any ideas of further collaboration, or whether this could be established in a potential third or fourth wave?
Yeah, thank you very much for that question. As you know, this hit us very quickly and very hard, and over the course of 1 week, essentially we lost 5 of the 7 hospitals across Greater London providing cardiac surgery. So basically in 1 day, between ourselves and Harefield, we had to take over all of the referrals that had been building up over the last 10 days or so. And that meant that we had to really change the way that we worked quickly so that we could bring imaging and referrals from hospitals we'd never worked with before. And between the 2 hospitals, we operated on referrals from 42 different referring hospitals from all across the southeast of England. I think going forward, there's never been a collaboration like this in cardiac surgery, despite the fact it's the National Health Service in London. And now going forward, there's still weekly meetings going on to look at the recovery of services, to make sure there's equity of access for patients now awaiting elective cardiac surgery across London, to ensure that all the centres, patients, no matter where you live, still have access to surgery, despite the fact there's different peaks in different areas of London.
Do you imagine that this extraordinary collaboration may pay dividends in the post-COVID era? Will you be more active in clinical research together? Will there be a consortium for a longer-term follow-up of patients, to study cardiothoracic pathology irrespective of COVID?
Yeah, thank you, Dr. Puskas. Absolutely. I think this has set up a dialogue between all of the cardiac surgery centres. As I say, that goes on weekly at the moment on a clinical basis, but going forward, I'm sure it will go into research as well. I mean, we've managed to collate all of this patient data from all of these hospitals during COVID. And I think going forward, as we start to get back to normal, it will make research collaboration much easier to perform.
Never waste a good crisis. Something good must be made of this atrocious series of events. I think this is a good thing. I would encourage you to keep amplifying it.
I think it's been very humbling for everyone, and everyone's appreciated support from each other.
There's the truth.
Yeah.
Right. I think we should get ready for your next presentation, Martin, this time talking about the results of the multi-center study for patients on the elective waiting list waiting for cardiac surgery.
I'd like to thank the Society for giving me the opportunity to present on behalf of my colleagues at the 7 contributing centres to this multi-centre prospective cohort study of patients on the elective waiting list for cardiac surgery during the COVID-19 pandemic. As you are all aware, a level 4 emergency was declared in January 2020 due to the worldwide COVID-19 pandemic. Elective cardiac surgery across the United Kingdom was postponed due to redeployment of staff and repurposing of intensive care units for COVID-19 patients. We know from historic studies that there's a small but significant mortality associated with patients awaiting elective cardiac surgery. And the aim of this study was to determine the outcome of patients waiting for cardiac surgery at the beginning of the COVID-19 pandemic in the UK. So in March 2020, a study was designed at St Bartholomew's Hospital in London to assess the provision of cardiac surgery during the COVID-19 pandemic. All centres in the United Kingdom were invited to participate for this waiting list section, of which 7 centres accepted. The study population included all patients on the elective waiting list for cardiac surgery at these 7 centres on the 1st of March 2020. And primary outcome was to have undergone surgery, percutaneous therapy, or have died as assessed on the 1st of August 2020. Data was collected at individual centres and submitted anonymised via a secure data portal. These are the high-level results, and we can see that across the 7 centres, there were 1,097 patients awaiting elective cardiac surgery on the 1st of March 2020. Of these, 52% remained on the waiting list in August 2020, 6 months later. Primary outcome was met in 528, or 48% of patients, of which 492 had undergone elective surgery. 26 had urgent intervention, of which 20 had surgery and 6 had percutaneous intervention. And unfortunately, 10 patients had died without intervention on the waiting list. For those undergoing elective surgery, there were 492 patients who had been on the waiting list for a mean wait of 166 days. Mean age was 65 years and 73% were male. As expected, the majority of procedures were coronary artery bypass graft or aortic valve replacement, with a distribution across the other expected operations. In-hospital mortality for these patients was 2.3%. Of those undergoing urgent intervention, this occurred at a mean wait of 172 days. You can see that the majority underwent the operation that they were originally waiting for, and 6 patients had undergone urgent PCI or TAVI. There was no in-hospital mortality in this group. So in conclusion, the COVID-19 pandemic has caused significant disruption to the provision of elective cardiac surgery across the United Kingdom. Half of patients on the waiting list at the start of the pandemic were still awaiting surgery 6 months later, more than twice the 18-week target. There was a 1% mortality of patients whilst waiting for surgery in this first 6 months of the study. And perhaps most importantly, we've successfully performed a multi-centre study during the pandemic through the hard work and collaboration of colleagues at all of these centres. And I would specifically like to acknowledge the centres and the contributors from these centres that have worked so hard during these hard times to contribute to this study. Thank you.
Thank you once again. I think impressive results. Dr. Puskas, I don't know if that 1% mortality on the waiting list is shocking to you, based on the comments that you were saying that in America people are so scared or they don't even want to consider an intervention.
Yeah, my concern is that there were, at least in America, in New York, where the peak was so violent at the beginning, I think that many more than 1% of people died, but they weren't on the list. They never presented themselves. They hid in their homes and died in their homes. That said, what Dr. Yates has presented is 1% in half a year. It's a 2% annual rate of mortality awaiting cardiac surgery, which is probably consistent with historic norms. Right? Delay of elective surgery produces a 1 or 2% annual mortality, so it's interesting that your population, didn't suffer a dramatically worse mortality rate waiting in the pandemic than they might have waited while waiting for other reasons in other times. But again, I think there's risk of a real sample error, that patients aren't on that list who should be on that list because they were afraid to present to any physician during the pandemic.
Yeah, thank you for those comments. I think the waiting list is a big issue for cardiac surgery patients in the UK. The cohort for this study was just those patients that had already made it onto the waiting list before the pandemic struck us in March of last year. And really this was designed to see what would happen to those patients and really would they ever get an operation. This was the first 6 months and we've now got the 1 year data, and actually only 2 more patients have died waiting. So the mortality is only 1.2% a year.
Dr. Yates, did the onset of the pandemic decrease the rate of patients being added to the list? Was there, can you say that referrals for cardiac surgery declined or were steady with the onset of the pandemic?
That's not specifically part of this study, but I know we have looked at that, and absolutely. So from April of 2020, the additions to the waiting list dropped dramatically. And I think that was for 2 reasons. As you said, there's a significant number of patients that never made it to the time when they could be referred for cardiac surgery, either through their choice or because they were too unwell. Patients that were referred at that time that ordinarily we may see electively in clinic even if they were presented with a myocardial infarction, we may send home and do their operation as an outpatient. That stopped, and you would only have an operation done as an inpatient. So patients that previously we may have added to the waiting list, we would keep in hospital, even if they stayed for longer until they got their surgery. And again, as you said, this was a collaboration between 7 centres across the UK and many people I'd never worked with before that we managed to make work right at the peak of the pandemic. So very grateful to all of them for being included in this.
And great work that you've presented on behalf of a collaboration that frankly is inspiring. So congratulations, not just to you, but to all your collaborators and the people.
Yeah, we're very grateful for their
and a central system of reallocation to provide ongoing service in a pandemic. Well done. The last presentation for this session is entitled Assessment of Patient Satisfaction and Experience During the COVID-19 Pandemic in a Cardiothoracic Unit. The speaker is David Schilero.
Good afternoon. My name is David Schilero, and I've spent the past year working in the unit of cardiothoracic surgery in St. Bartholomew's Hospital. Today, I'm going to present a study carried out by our local group of junior researchers on the patient experience of the hospital admission at the end of the first wave of the COVID-19 pandemic. Urgent procedures continue to be performed at BART during the pandemic. Therefore, to allow a safe and COVID-free surgical pathway, we had to implement new protocols. Patients were asked to wear face masks, self-isolate for 2 weeks before admission, and instead of coming to clinics, they had to be admitted 2 days in advance to be swabbed and to carry out the preoperative investigations. They had to be admitted inside rooms and asked not to leave the room before the swabs results came back. Also, visitor restrictions were implemented. Our objective in this study was to investigate the impact of these measures on the patient's psychological well-being and on the standard of care we delivered. We enrolled 206 patients discharged from June to August 2020. The majority, 45%, came from cardiac surgery, 30% from interventional cardiology, and 25% from thoracic surgery. We asked them to fill a survey composed of 38 questions before discharge. The maximum score of our survey, indicating maximum satisfaction, corresponded to 170 points. Of all patients, 70% were male. 60% of the procedures the patients received fell under the NCPOD category of expedited surgery, and 40% was urgent surgery. Only 3% was an emergency. 50% of our patients were 61 to 80 years old, and in total, about half of the enrolled patients stayed more than a week in hospital, and this seemed to affect our outcome. Talking about the results, we wanted to address 5 main problems and how these were perceived by patients. First of all, adherence to wearing face masks. Just 76% of the total were clear how and where to wear it, and 39% had to be reminded more than once. These appear more often in males, and even though half of the patients felt nervous seeing staff using masks, 9 out of 10 found it a reasonable precaution to prevent the spread of the infection. Getting to isolation, a large portion felt unhappy of their families not being able to visit, but the majority, about 2/3, were satisfied by the possibility of calling them regularly, and 3 out of 4 felt they received adequate help by the healthcare staff when needed to communicate with family. Talking about anxiety, 1 out of 10 of our patients had a past medical history of anxiety or depression. Nonetheless, the fear of getting COVID in hospital was felt by 30% of them, regardless of the history of anxiety. And in the age group who felt significantly more vulnerable and afraid of catching COVID were the over 80s. Talking about the procedures changes and delays, 8% reported that their procedure was actually changed as a consequence of the pandemic, more in cardiology, and 1 out of 10 patients would have considered an alternative treatment entailing a shorter hospital stay. A large amount of patients, about 8%, did not believe anyway their admission were delayed unreasonably, but also wouldn't want to delay it anymore if they were offered to. The overall score we got was 120 over 170 in terms of satisfaction. So this score was about 70.6%. We can tell that overall the satisfaction appeared adequate, although compliance was affected, especially in urgent settings. Also, longer ICU stays and over 80s seem to have a worse overall experience. Most patients were not willing to postpone surgery despite anxiety. They might have recognized that postponing could have been counterproductive. And also, self-isolation is difficult for all. Explaining and offering human and technological support to our patients help them cope with its challenges. We should also carry on focusing on the impact of COVID-19 has on patients' mental health. In conclusion, the attention to how patients perceive the care we deliver should never take a second place to our effort to treat their condition. With this in mind, I leave you with a quote from the World Health Organization Constitution. Health is a state of complete physical health and social well-being, and not merely the absence of disease or infirmity. Thanks for your attention. Good afternoon, my name is Davide Schiliro, and I've spent the past year working in the unit of cardiothoracic surgery in St. Bartholomew's Hospital.
We've commented numerous times in this session on the psychological impact of the pandemic and its impact on mental health for individual patients and even for society as a whole. You know, every generation has had its trials. We have been fortunate not to have a major war that's caused a draft.
Patients were
our parents and grandparents did, or at least my parents and grandparents. Perhaps you're too young, my friend. But your grandparents and great-grandparents then did our trial, if you will. And it leaves a social and psychological scar. I wonder at that last quote, it sounds very nice, but is the World Health Organization really putting social well-being on the backs of physicians and surgeons? You know, I think it's important not to there's this thing called mission creep. You know, cardiothoracic surgeons are supposed to fix the heart and the lungs and the esophagus and send the patient home. I don't think we're expected to guarantee eternal happiness for every patient. I think we're supposed to make well and send them back to their own lives. You know, the U.S. Constitution guarantees that you have an equal right to pursue happiness. It doesn't guarantee that you will be happy. What are your thoughts?
Absolutely. Thank you very much for your comment, Mr. Puskas. We focused on what the results of this study were, and absolutely we can guarantee the outcomes of happiness, but maybe we can still follow the idea and try to implement some of the perioperative implementations that seem actually to make a big difference on the overall stay of the patient. So maybe some result is achievable if we aim for the ideal target. When we realize that, for example, urgent settings and over 80 patients in their over 80s were particularly affected by were particularly frightened of catching COVID with significant p-values and results, we started to think about what could our actions be as a consequence. For example, we came up with the idea of implementing the technological support that we are providing to the patients, because there was a lot of focus on that, but probably the most vulnerable patients in that setting would have been the elderly, probably because they can't receive they can't receive the technological support that we give sometimes in the same way that other patients will do. For example, patients operated for cancer in thoracic surgery, they're usually younger and they responded much better to the technological support provided. So we could see there was a good response overall, but in certain settings, for example, in cardiac surgery or in interventional cardiology, where the patients are usually more than 80 years old, that's probably where we could focus more in delivering and helping the patients get in touch with family and feeling less lonely in hospital. Of course, without the possibility of achieving the 100% result in that, but that's still the target to aim for, I guess, to improve slightly their general experience. A large amount of patients, about 80%, did not believe anyway their admission were delayed unreasonably, but also wouldn't want to delay it
You have a
anymore
question,
if they
Dr.
were offered
Lopez?
to.
No, I was actually quite
overall
surprised
score
by the
we got
results. I
was
would have said that the
120
patient would have
over
been less happier
170
than they
in
were.
terms of satisfaction.
So actually,
So
I
this
think
score was
well done
about
for all the efforts in
70.6%.
pursuing not only
We can tell that
reassurance
overall
and
the
good
satisfaction
clinical
appeared
care, but
adequate, although
also trying to
compliance
help
was
people to
affected,
have
especially in
their
urgent settings.
stay in hospital
Also, longer
far
ICU
more
stays
comfortable.
and over 80
You know, I
seem
think
to
that
have
your
a
impact,
worse
the
overall
impact of
experience.
heart surgery in
Most
general
patients
and
were
the
not
pandemic
willing to
in
postpone
particular
surgery
has been
despite
most harsh on
anxiety.
the
They
elderly.
might have
They
recognized that
tend to be
postponing
socially
it could have
isolated,
been counterproductive.
and
And
the
also,
pandemic has
self-isolation was
isolated
difficult
all
for
of
all.
us socially.
Explaining
And
and
I think
offering
that
the
burden,
human
that psychological burden, is
support to our
profound
patients helped
for the
them
elderly.
cope with its
And
challenges.
it should not
We
be
should also
ignored.
carry on
That is
focusing on
a
the
real
impact that
burden,
COVID-19 has
it's
on
been a
patients'
crushing
mental
burden for a
health.
long, long time.
In conclusion, the attention
Absolutely. We had a couple items in the questionnaire addressing exactly this point, asking the patient if they were clear whether they could, when and whether they could self-isolate before and after the admission, and whether they had enough support. And of course, the most vulnerable of all ranges was, of course, the over 80s, which actually is increasing in cardiac surgery because it's a big share of our patient that needs definitely to be addressed in that sense. So there is, of course, something that we can do inside of hospital, which is in a way the setting where we've got more control. But outside of hospital is another actually a very important setting where we should focus our effort because a lot happens there, and we should ensure that kind of support. We are still aiming to achieve that goal. Maybe starting from the in-hospital setting, but that's, of course, as you say, a very important burden, and their isolation is being particularly important in this period, and they're particularly frail. But yes, I completely share your view.
Thank you very much, David. I think we should start wrapping up this session, which has been amazing. We learned a lot about COVID and the impact that it has had, not only in clinical results, but also on patients' perspective and on bringing up teams together.
Thank you very much.
I think you're on mute, Dr. Puskas.
Thank you. It's been an outstanding session, and I congratulate the SCTS on designing it. We cannot have an annual meeting of a renowned cardiothoracic surgical society without acknowledging the impact that COVID has had on our lives and our practice and our patients over the last year. And I think these presentations very well described that impact on all of us. So congratulations to the organizers and especially to the presenters and participants. And thank you, Dr. Lopez Marco, for co-moderating with me.
Thank you very much.
Well, and enjoy the rest of the Congress.
Bye, everybody.
Bye now.